Good afternoon and welcome to Internal Medicine Grand Rounds. There is no commercial support for today's program. The speakers and planners have disclosed no relevant financial relationships with any commercial interests. If you have a question for the presenter, please hold until the Q&A segment at the end of the presentation. And if you're attending virtually, we have a sign-in link in the chat section for you to click on and sign into the activity. And if you have a question and you're viewing virtually, please enter it into the Q&A bubble and we'll ask that question for you at the end. It is my pleasure to introduce our guest speaker, Dr. Stephen Barker. Dr. Barker is a third-year internal medicine resident here at Northeast Georgia Medical Center. He is from Middle Tennessee. He completed his undergraduate and graduate degree from Lipscomb University. Dr. Barker attended medical school at Campbell University School of Osteopathic Medicine. His plans are to attend University of Texas, San Antonio for a one-year fellowship in hospice and palliative medicine, and then further specialize in hematology and oncology. In his spare time, he enjoys spending time with friends and family. Join me in welcoming Dr. Barker.
Well, good afternoon, everyone. I appreciate the opportunity to be here and speak today. Today I will be speaking about cardiovascular complications of oncologic therapies from an internist perspective. So as mentioned previously, I have no relevant financial or professional relationships with any companies, organizations, or entities to disclose today. And I will also give a disclaimer, this is a very large topic, and it's a very much fast-growing topic. I do not claim to have an exhaustive presentation, but to the best of my knowledge, have presented the data as it is today. So just a brief outline of the presentation. We'll start with an overview of oncology therapies and cancer survivors, then go into specific cardiovascular complications of chemotherapy and other oncological therapies, and then we'll talk about radiation therapy, risk factors, monitoring of cardiovascular toxicity in cancer patients, and cardiovascular risk reduction and management of complications. So just starting out today, as of 2022, it was estimated that there were more than 18 million cancer survivors in the United States. And of these 18 million, approximately 35% of these cancer survivors will experience some form of cardiovascular complication from their treatment. This includes heart failure, coronary artery disease, arrhythmias, and so on. So there have been a number of analyses to look at, is there increased risk in cancer survivors just because of baseline previously undiagnosed cardiovascular disease, or is there, for some reason, an increase in risk due to these oncological therapies? And those studies did show that adult cancer survivors have a significantly higher risk of cardiovascular disease, especially heart failure, independent of traditional cardiovascular risk factors. And we'll go a little bit more into that. And this just highlights that there is a unmet need in treating these patients, and also for recognizing these complications and potential causes of these complications from an oncological standpoint. And I believe this is relevant for oncologists, cardiologists, but even beyond that, primary care physicians, hospital medicine physicians, palliative medicine, all of these team members and the care team and treatment team of cancer patients can assist and recognize these complications. So this comes from that study in 2022 by Dr. Florido and all the other people that worked on this study. But they were looking at oncology patients and comparing them to patients without cancer and trying to determine, do these patients have that increased risk of cardiovascular disease? And they used two models in this study. We'll get to those in a second, but just as an overview, There are several proposed pathways in which cancer patients may have increased cardiovascular risk. Of course, one we'll talk about today is the toxicities from cancer therapies. But underneath that, there are also physiological effects of cancer, such as inflammation, oxidative stress, that also contribute to this, and that's not to be overlooked. And then common biological predispositions, such as genetics and clonal hematopoiesis. And then, of course, there's always the traditional risk factors that we're well aware of, such as smoking, diabetes, obesity, and hyperlipidemia. Many of these risk factors are present in cancer patients as well. So how do we tease out how much of this cardiovascular toxicity is related to those underlying factors versus cancer? So these two models that they used specifically adjusted for demographics in Model 1. So Model 1 adjusts for age, sex, race, and educational level. And for that adjustment, they did an analysis for increased risk of cardiovascular disease, especially heart failure. And they saw that there was a 42% higher risk in cancer patients adjusting for those variables in cardiovascular disease. Specifically looking at heart failure, there was a 59% increase. So just adjusting for those factors and not even considering underlying disease and traditional risk factors, we see that there is an increased risk. That's why they bring in Model 2, and they looked at adjusting for Model 1, but then adjusting also on top of that for those traditional risk factors that we're all familiar with, such as the ones I mentioned earlier: obesity, diabetes, hyperlipidemia, smoking. And in that study, or in that test, they saw that there was a 37% increase in cardiovascular disease, independent of all of those risk factors. So these oncology patients have 37% increased risk cardiovascular disease, and in heart failure, a 52% increase. So this is another figure from that paper that just kind of, it's a forest plot indicating the trend and statistical significance of the increased risk observed. There was only one cancer, prostate cancer, that did not meet statistical significance, but overall it does show a trend towards higher risk of cardiovascular disease. This is from another paper in the New England Journal of Medicine, and I think illustrates very well all the many different factors that can contribute to the increased cardiovascular risk. We're going to talk about a number of these today, but when we're talking about the cardiovascular system, we're not just talking about the heart tissue, myocardium, coronary artery disease, or the coronary arteries. It also involves the vascular system. And we will not go into cardiac tumors today, and then other metastases, other hematological conditions like amyloidosis and metastasis. We will not go into those today, but this just shows a good summary of all of the different ways the cardiovascular system is affected by hematological and oncological conditions. So without further ado, going into the chemotherapies, we'll start with our quote-unquote traditional chemotherapies, and one of the most commonly cardiotoxic chemotherapies that I believe we're all well aware of is anthracyclines. So anthracyclines such as doxorubicin, epirubicin, daunorubicin, idarubicin, valrubicin, and mitoxantrone have been shown to have increased risk of heart failure. So obviously these anthracyclines have that ending rubicin, and so that's very important to help us kind of help keep in our mind these chemotherapies classified. So anthracyclines work by intercalating DNA and inhibiting topoisomerase 2, causing disruption in DNA replication and transcription. So it has been seen that anthracyclines cause a dose-dependent cardiotoxicity. They also cause other side effects of chemotherapy at large, such as myelosuppression and alopecia and mucositis. But acute cardiotoxicity of anthracyclines can also occur not just the long-term or late anthracycline toxicities. And that often presents as non-specific ST segment and T-wave abnormalities on EKG. And then also, of course, the late anthracycline cardiotoxicity. So that's an interesting one because it's dose-related and it's also cumulative. So any dose that someone receives through their journey in oncology, it adds into that cumulative dose. And at sufficiently high doses, it can result in congestive heart failure and left ventricular dysfunction. The proposed mechanism for this is through creation of reactive oxygen species, such having to do with iron metabolism. But this causes oxidative stress and causes damage directly to the mitochondria, which further causes damage to cellular lipids, proteins, DNA, and triggers apoptosis. And then the prevalence of cardiomyopathy increases significantly when there is doses of doxorubicin greater than 550 milligrams per meter squared. So doxorubicin is one of those chemotherapies that is dosed based off of body surface area. So how do we, first of all, manage anthracycline cardiotoxicity? So as you'll see throughout this presentation, a number of these management protocols don't vary too much from traditional management of ACS and cardiomyopathy, but there are some specific things that we can do to, one, either help mitigate these toxicities, and two, continue therapy without causing some of these toxicities. So anthracyclines are one of those. Overall, we'd like to reduce the dose and minimize anthracycline use if possible. So reducing the total dose to less than 400 milligrams per meter squared and changing the administration from a rapid infusion to a continuous infusion does help with this. And then there are also newer liposomal formulations of anthracyclines that also reduce this toxicity. One meta-analysis of 4 randomized controlled trials demonstrated that liposomal doxorubicin significantly reduces the risk of heart failure compared to doxorubicin without the liposomal formulation. Another important factor is in reducing the toxicity is administration of dexrazoxane. This is a derivative of EDTA, and it can reduce the myocytes' free iron by producing free radicals that decrease oxidized iron levels during anthracycline infusion. This is typically reserved for a later line. If patients have not yet gotten close to that 400 or 500 milligrams per meter squared, they'll try not to use it. Because it does carry its own complications, dexrazoxane can worsen thrombocytopenia and granulocytopenia, which is often an issue with patients receiving these chemotherapy agents to begin with. So, but that is something that can be used to mitigate this risk or reduce the risk. Moving on to alkylating agents, these are agents like cyclophosphamide, ifosfamide. You can see the full list here. Also in this category is cisplatin and carboplatin, oxaliplatin, so all the platinum-based therapies. These agents work by causing crosslinks and or strand breaks in DNA and causing cell destruction based off of that. So the mechanism of injury to the cardiovascular system for these agents is thought to be related to endothelial and myocyte injury mediated through toxic metabolites. In alkylating agents, acute toxicity can last up to 6 days, or the effects can last up to 6 days, but long-term effects are usually not seen in those who survive. So the acute toxicity commonly presents as ACS, so this is a spectrum. We all know that ACS is a spectrum starting with just angina pectoris all the way up to myocardial infarction. But cisplatin, among those listed, is unique in that it can cause late cardiovascular complications such as hypertension, left ventricular hypertrophy, myocardial ischemia, and MI. And that's as many as 10 to 20 years after remission of cancers. This says testicular cancer here. That's where that was studied. But any cancer treated with cisplatin does carry that risk. Co-administration of anthracyclines and radiation obviously is going to further increase this risk. So this goes for basically everything we're going to talk about today. The more agents that are cardiotoxic we add to the regimen, the further we increase that risk of cardiovascular toxicity. And then one other therapy in this category, mitomycin, has been used in the treatment of many solid tumors. It has also been associated with the development of cardiomyopathy as well, particularly when in combination with anthracyclines. So, moving on to our next agent. I think I went too far. No. So these are the antimetabolites. These are folate antagonists, which consist of methotrexate, pemetrexed, and pralatrexate. And then we have the purine analogs, which we may be a little more familiar with, such as 6-mercaptopurine, thioguanine, fludarabine, clofarabine, pentostatin, and nilarabine. And then the pyrimidine analogs are another category in the antimetabolites. These are agents like 5-fluorouracil, capecitabine, cytarabine, gemcitabine, azacitidine, and decitabine. So these particular agents work by mimicking natural nucleotides and their precursors, which when they are incorporated into DNA, they disrupt DNA synthesis and RNA synthesis as well during the S phase of the cell cycle. We'll look at just a few of these agents. Toxicity of 5-fluorouracil, for example, which is commonly used in treating of many solid tumors, can cause ischemia on any level, from angina pectoris to acute MI. However, this is one that we can re-challenge patients with after the ACS has been addressed and treated. And when we re-challenge, it does sometimes cause reproduction of those symptoms. So in those cases, the treatment is going to be to discontinue that agent and try to find another one that can be used. Capecitabine is thought to be less toxic than 5-fluorouracil, but also does carry that risk of ACS. So, and as I mentioned before, treatment is to discontinue and treat the ACS. Treatment here for the ACS is going to be with many of the usual treatments for ACS, such as antiplatelet therapy, beta blockade, anticoagulation, nitroglycerin. You all are aware of that. Moving on to our next class of medications, the antimicrotubule agents. So this is commonly known antimicrotubule agents such as paclitaxel, docetaxel, epithalons, the vinca alkaloids such as vincristine, vinblastine, and vinorelbine, vindicine, and vinflunine, and then colchicine as well. These agents work by inhibiting polymerization or depolymerization of microtubules and thus affect cell replication in the cell cycle. Of these agents, paclitaxel has been reported to cause sinus bradycardia, heart block, PVCs, and ventricular tachycardia. It has also been shown to cause thrombosis as well. So in a large study of approximately 1,000 patients, the incidence of cardiac toxicity, mostly bradycardia, was 14%, and most incidents, like I said, were bradycardia at 76% of those 14%. And vinca alkaloids, they have also been shown to cause autonomic neuropathy, angina, with ECG changes, myocardial ischemia, and MI as well. And then the mechanism for that ischemia with the vinca alkaloids is thought to be secondary to coronary vasospasms or Prinzmetal angina. So moving on to Our next class of medication, thalidomide, excuse me. Thalidomide is used to treat a variety of hematological malignancies, as well as solid malignancies. And overall, this medication is relatively safe with regard to cardiovascular complications, but it has been shown to cause some edema, sinus bradycardia, and rarely DVT. Etoposide, which is a topoisomerase inhibitor. This medication works by topoisomerase, as you know, is the enzyme that is responsible for decoiling DNA during the replication cycle. And if we block that, then DNA breaks do occur, and because of those breaks, apoptosis occurs on a cellular level. So etoposide is used mainly in the treatment of in testicular tumors and small cell lung carcinoma. And then it does have hypotension as a side effect, although myocardial ischemia and MI have been noted. So now we move on to a whole other segment or sector of oncology therapies, which is a very fast-growing class of medications, and this is the monoclonal antibodies. I'm going to talk about, on this slide, just the general side effects from monoclonal antibodies, and then we'll go into each one individually. But there are many of these agents. It's a very fast-growing field, and there are many new treatments, which we may not have established what the cardiovascular effects of these medications are at this point. But these are agents like alemtuzumab, bevacizumab, rituximab, trastuzumab. So they have many targets, and they're all monoclonal antibodies. But as a general class of monoclonal antibodies, the adverse effects, one of the big ones is going to be hypotension, and this is due to the severe inflammatory response that these monoclonal antibodies create via release of many cytokines. So along with that, it's going to be fever, dyspnea, hypoxia, and of course, we never can eliminate the risk of death from these medications. Each monoclonal does also carry some of its own specific toxicities, and one of the other common ones can also be myositis or myocarditis with significant troponin elevation, and we'll talk more about that later. So moving on to alemtuzumab. Alemtuzumab is a humanized IgG1 antibody that is directed against CD52. It's used in the treatment of some hematologic malignancies. Alemtuzumab has been associated with infusion-related reactions, but also, as mentioned before, hypotension, specifically in the cardiovascular system. It also can carry risk of left ventricular dysfunction, although that is more rare, and that has been reported in a treatment of patients with cutaneous T-cell lymphoma who had previously undergone multiple chemotherapy regimens. So it does seem to be related to the alemtuzumab, but it may also have some underlying disease from previous regimens. Treatment for the monoclonal antibody reactions and or complications. So if the patient has an infusion reaction, we'll want to treat with antihistamines, acetaminophen steroids to slow down that reaction and also slow down the infusion as part of that treatment. And then for treatment of LV dysfunction, we want to also talk about the guideline-directed medical therapies as well. With bevacizumab, this is a humanized monoclonal IgG1 antibody that binds to and inhibits the activity of human vascular endothelial growth factor. And it has been approved for use in combination with 5-fluorouracil for treatment of metastatic colorectal carcinoma. And in the trial for this approval, one of the identified cardiovascular complications is worsening hypertension. It's a commonly observed side effect, and it can be very severe, all the way up to the extent of having or causing hypertensive crises or encephalopathy and subarachnoid hemorrhage. So these are important I have seen this uncontrolled hypertension from this therapy previously while inpatient, so definitely one to consider. And, discussing the management and treatment with the multidisciplinary team is going to be important. We may not always just stop this medication just because of the hypertension, unless it was, causing severe hypertension that can't be controlled otherwise with your standard treatments for hypertension. That risk is also going to be increased if a patient has previously received anthracyclines, had left chest wall irradiation, and so on. Moving on to rituximab. This is a chimeric murine human monoclonal antibody against CD20. Most of the adverse effects are related to the infusion, and this particular agent is used in many different diseases, both oncological and hematological, one of them being like ITP. Rituximab is used in many different scenarios, so not just restricting this medication to cancer patients. So many rheumatological conditions are also treated with rituximab. So overall, rituximab has less severe reactions, but does have the same risks of hypotension, angioedema, hypoxia, and bronchospasm, which has been seen in up to 10% of cases. And then overall supportive care is recommended, but it is important to recognize that this particular agent is also combined with like other agents that we've already talked about. One very commonly known regimen, and as an example, is the R-CHOP regimen. So just keeping that in mind is important. Now we move on to trastuzumab. So trastuzumab is a recombinant humanized IgG1 monoclonal antibody that selectively binds to the human epidermal growth factor receptor 2 protein, or HER2. In the initial clinical trials of trastuzumab, use of this agent alone was associated with a 2% risk of developing significant cardiac dysfunction, classified with the New York Heart Association classification of level 3 or 4 heart failure. And this increased up to 16% when trastuzumab was used in combination with anthracyclines and cyclophosphamide. And this treatment is going to be, or has been approved for the treatment of breast cancer that overexpresses HER2. And this particular variant of breast cancer, that is HER2, has an approximately 25 to 30% increased risk of or a poor prognosis, and it carries a poor prognosis, and it's expressed in 25 to 30% of breast cancers altogether. However, in more recent trials, monitoring left ventricular function before and during treatment and not administering these drugs simultaneously have substantially reduced the toxicity. Comparing to doxorubicin and the anthracyclines, trastuzumab is it's unique in that it is not a dose-dependent, but more of a lifetime exposure risk. So it's more time-dependent. Trastuzumab does cause left ventricular systolic dysfunction with symptoms of heart failure in 3 to 7% of patients, and it is more common in patients older than 50 years old, and also with concomitant anthracycline use. But also importantly, trastuzumab-induced left ventricular dysfunction is reversible. So throughout therapy, we'll talk more about monitoring and things like that as we go along, but you do want to get a baseline echocardiogram prior to starting trastuzumab, and periodically through treatments, you want to repeat an echo to reassess where the ejection fraction is. If there is some drop in the ejection fraction, more than 15% or 10 to 15% below normal levels, then you do want to stop trastuzumab therapy. Patients that achieve normalization of their ejection fraction after discontinuation can resume therapy as well, so that's also important. And then retrospective data has shown that patients whose ejection fraction remains greater than 50% may continue treatment without long-term cardiac effects. Yesterday in our noon conference, Dr. Mee, who's one of our chief residents here, talked about a particular parameter on echocardiograms, such as global longitudinal strain. She was presenting on right heart failure. It was a great presentation, but that particular parameter is used in monitoring for cardiomyopathy in these patients that are receiving trastuzumab because it's very sensitive. And that is because it's measured on the level of percentages. So prior to seeing any reduction in ejection fraction, if you see a relative decline in global longitudinal strain of greater than 15%, you can consider that this patient has subclinical left ventricular dysfunction, and this should prompt consultation with a cardiologist. So moving on, this is starting another section of therapies that are tyrosine kinase inhibitors or small molecule inhibitors. The first agent I'm going to talk about today is imatinib. This agent is frequently used in treatment of chronic myeloid leukemia and other malignancies which express the BCR-ABL fusion or the Philadelphia chromosome that we all learned about in medical school. Imatinib mesylate is associated with a significant incidence of edema, which can progress to severe fluid retention and result in pericardial or pleural effusions, and as well as generalized third spacing on physical exam. Beyond that, those are the main cardiovascular complications that I could find. There are perhaps more, but that's what I was able to find on my literature review. Moving on to Bruton tyrosine kinase inhibitors. These are medications like ibrutinib, which is a first-generation BTK inhibitor, acalabrutinib, and zanubrutinib. Acalabrutinib and zanubrutinib are both second-generation BTK inhibitors. These are used to treat CLL, Waldenstrom macroglobulinemia, mantle cell, and marginal zone lymphomas. So the main cardiovascular adverse effect here is atrial fibrillation. It can also cause hypertension, and those two complications are more prominent with the first-generation BTK inhibitors like ibrutinib. They may increase risk for bleeding, and it's also recommended that any patient on DOACs that is receiving a BTK inhibitor should have a dose reduction in the DOAC based on this. It does interfere with CYP3A4 and thus interferes with clearance of DOACs. It does, because of that, does also affect patients on other cardiovascular treatments like verapamil, diltiazem, digoxin, and amiodarone. So that is also important to keep in mind because those in of themselves, if are at super therapeutic levels, can cause arrhythmias, and that may be attributed to the BTK inhibitors if not diagnosed correctly. Another newer class of medications based off of newer advancements in treatment of non-small cell lung cancer are the anaplasma lymphoma kinase inhibitors, or ALK inhibitors. They're used primarily in the treatment of ALK-positive, fusion-positive metastatic non-small cell lung cancer, which account for approximately 5% of non-small cell lung cancer. So just as an example, crizotinib is a first-generation ALK inhibitor, and then alectinib and lorlatinib are second-generation ALK inhibitors. The most common cardiac complication associated with ALK inhibitors is bradycardia. There have been similar rates in bradycardia between the first-generation and second-generation ALK inhibitors. And then beyond bradycardia, it also has been shown two other side effects, but hypertension has been observed in patients receiving brigatinib, which I did not previously mention, but that was, and lorlatinib. So Patients receiving brigatinib or relatlimab do have increased risk of hypertension, as well as hypercholesterolemia and hypertriglyceridemia, specifically with lorlatinib with the dyslipidemia. Moving on to next class, which is epidermal growth factor receptor inhibitors. These are, again, predominantly used in treatment of non-small cell lung cancer with EGFR mutations. And one example of these medications that is commonly used is osimertinib. Osimertinib is a third-generation EGFR inhibitor, and it is associated with a decline in left ventricular ejection fraction, as well as QT interval prolongation. Osimertinib also shows 2 to 6 times higher odds of heart failure being reported in pharmacovigilance studies and databases. And then all patients receiving epidermal growth factor receptor inhibitors should have cardiovascular risk factors assessed and undergo baseline echo with echo surveillance. And then all patients require baseline EKG due to the fact that these medications can prolong QT interval. And obviously we want to avoid any additional prolonging medications that can cause prolonging of the QT interval as well. Next, we move on to the immune checkpoint inhibitors. So these are a larger class of medications, but ones that we're very frequently used in many different cancers. They're monoclonal antibodies that generally target key regulatory proteins such as PD-1, PD-L1, and CTLA-4, which are programmed cell death protein 1 and death ligand 1, and cytotoxic T lymphocyte-associated protein 4. They can be associated with a broad range of cardiovascular toxicities, although one of the most common is myocarditis, and is a very frequently described cardiovascular immune-related adverse event. But it can also cause other conditions such as pericardial disease, vasculitis, arrhythmias, atherosclerotic and thromboembolic events, and declines in left ventricular ejection fraction without evidence of myocarditis. All of these have been reported. And as I mentioned, myocarditis being one of the most common, typically it manifests between 30 and 50 days from the first immune checkpoint inhibitor dose, with the majority of cases detected within the first 3 months. However, I will say it can present as early as 1 week from infusion date. So that is something to keep in mind. Cases that typically present 1 week after infusion date can be more severe, and it is very important to recognize these immune-related adverse events quickly. So before starting one of these agents, you do want to assess a baseline cardiac troponin, and EKG should also be conducted to serve as a comparison between when you suspect someone might have one of these immune-related adverse events like myocarditis. You can see in myocarditis, when they get to that point, you can see very significant troponin elevations, and most patients with suspected myocarditis require inpatient evaluation. The gold standard for diagnosing myocarditis from ICIs is going to be an endomyocardial biopsy, which detects infiltration of macrophages and T lymphocytes and evidence of myocyte necrosis. Now, the number, I don't know the numbers on how often we actually get this biopsy because it is very invasive. There are other surrogates which could be used in conjunction with their overall clinical picture, such as aldolase, and then CKE and troponin elevation. All of these in combination can be used as well. You may see reduction in ejection fraction, as well as regional wall motion abnormalities, or decreased GLS on echocardiogram in a patient who has this myocarditis. But as I mentioned before, prompt recognition is going to be very important for the patient's prognosis, with one of these immune-related adverse events. So the treatment is going to be high-dose corticosteroids, and additionally, you can use immunomodulators such as tocilizumab, which is an IL-6 inhibitor. So now we're going to move on to different risk factors. Generally speaking, there are modifiable and unmodifiable risk factors. A number of these are similar to risk factors for cardiovascular disease in general, but specific to cancer survivors and cancer patients. Radiation therapy is going to be somewhat modifiable. I put it in the unmodifiable risk factor category. As our radiation treatments and modalities and methods have improved over the years, we do see less and less radiation induced toxicities, which we're going to talk about that briefly in a minute. But also there's unmodifiable risk factors such as age, pre-existing cardiovascular disease and metabolic abnormalities, and then many of our modifiable risk factors are going to be similar to early or other risk factors that you see in cardiovascular disease. But it is important that one of those modifiable risk factors is early cardiology referral. So if you suspect there's a cardiac toxicity or just want to anticipate it, early cardiology referral is something that we can do to help our patients. So moving on to talking about radiation therapy. As I mentioned before, this has gotten less and less, but radiation to the thorax can cause damage to the pericardium, the myocardium, valves, and coronary vessels, with the pericardium being the most commonly involved. The precise incidence of radiation-induced accelerated atherosclerosis is difficult to confirm, but it has been reported in patients who did not have traditional risk factors of coronary artery disease or diagnosed pre-existing CAD. It is estimated that approximately 50% of asymptomatic patients develop new myocardial perfusion defects as well. Clinically, most patients that are having ACS are going to present in the usual fashion. There's really no changes in that, but that's angina, dyspnea, heart failure as well. Sudden cardiac death has been also reported due to radiation therapy. And then as in general, radiation therapy to the thorax does cause fibrous thickening of the pericardium, as well as any tissue that is going to be in that field of radiation therapy. So excuse me a second. Late constriction can occur as well, and that can be independent of any episode of acute pericarditis from radiation therapy. And then also pericardial effusions are very common with this. It's typically an early presentation, whereas pericardial constriction is usually a late manifestation and usually appearing after 18 months. Valvular heart disease is also common after radiation because radiation causes that fibrous thickening. And the left-sided valves are more often involved compared to the right heart valves. And only a minority of patients with radiation-induced valvular disease have clinically moderate or severe dysfunction. The mean time from radiation to onset of symptoms is approximately 98 months for that. Management of radiation-induced cardiovascular complications is going to be, if it's ACS, it's going to be many of the same treatments that we use for treatment of ACS to begin with, as I've previously mentioned. But one consideration is that patients who have multivessel disease and might otherwise undergo CABG may have more difficult surgical cases due to the fibrous thickening of the tissues in the thorax. So now we're going to talk quickly about monitoring and risk reduction. I thought this was a great illustration overall. It's an overview of pretreatment evaluation, recommendations, assessment tools, and evidence gaps. So as I mentioned previously, we want to identify and treat subclinical cardiovascular disease and risk factors, optimize treatment of prevalent cardiovascular disease, perform targeted risk assessment to help inform cancer patients, and establish baseline cardiac function before starting many of these therapies. And then manage primary prevention and also surveil the cardiovascular disease. So these are a number of things that can be used, and we talked about a number of them. I'm not going to go into detail about specific risk scores today, but just know that there are these specific risk scores that can be used to help identify these patients and treat them appropriately. And this came from a study published in the Journal of the American College of Cardiology, actually this year, about a month ago. Well, I'll show you this article in a second. It was a very useful article, and for anyone that is interested in reading further, I highly recommend this article. This is a table also taken from that article. I thought it was a very good summary of what we talked about today. So specifically with anthracyclines, a number of these therapies, treating underlying disease and prevention treatment with ACE inhibitor, ARBs, beta blockers should be considered in these patients, especially ones that do have the left ventricular ejection fraction decline. And then also statin use. The same applies for HER2 targeted therapies, and then radiotherapy as well. And these are specific recommendations in a second table for surveillance. So, of course, I mentioned some of these as we went along, but echocardiogram, EKG, BNP, as well as troponins. The specific biomarkers like troponin and BNP may not be helpful in every case, but certainly a baseline would be helpful in any patient that you suspect could have a complication. And then these are additional recommendations for the BTK, ALK, and immune checkpoint inhibitors, and then also osimertinib, which is the EGFR. There are some cases in which we do allow for some quote-unquote permissive cardiotoxicity. And this is going to be a decision that is made in the context of a multidisciplinary team with the cardiologists, oncologists, and anyone else involved in the treatment team. And there are certain considerations for each one. For example, 5-fluorouracil, you can consider using nitrates and calcium channel blockers when you re-challenge a patient with 5-fluorouracil. But ultimately, if they do have a repeat coronary vasospasm, that would need to be something that you can stop that medication or stop that cancer treatment. And then, of course, any of these scenarios, decision-making should be highly involving the patient and other care team members. And then this is just another graphic that summarizes many of the things I've already talked about. I will not go into any further details on this graphic. And then next I do have two questions to assess our knowledge. So a 56-year-old woman is evaluated before starting treatment with trastuzumab for early stage HER2-positive breast cancer. She has no cardiovascular symptoms and has no exercise-related limitations. She does have hypertension and hyperlipidemia. Medications are losartan and atorvastatin. On physical exam, vital signs and other findings are normal. The breast surgery site has healed. Results of routine lab tests are normal. And findings on echo are normal with ejection fraction of 55%. Which of the following is the most appropriate cardiac surveillance for this patient? A, cardiac magnetic resonance. B, echocardiography. C, multi-gated acquisition scan or a MUGA scan. Or D, no surveillance.
Would you like us to answer?
Sure.
Excellent. I see a hand down here.
Yes.
B, echocardiography.
B, echocardiography. Very good. That is the correct answer. So anyone receiving trastuzumab, as I mentioned previously, should have a baseline echocardiogram that establishes their baseline function and then periodically should be assessed throughout their treatment. very good. And our second question, a 70-year-old man is evaluated in the emergency department for 3 days of palpitations and dyspnea. New onset AFib is diagnosed. He also has chronic lymphocytic leukemia. He began ibrutinib 1 month ago. On physical exam, pulse rate is 128 and irregular. Oxygen saturation is 95% with the patient breathing ambient air. Other than rapid irregular rhythm, the cardiopulmonary exam is normal. Splenomegaly is present. There is no lower extremity edema. Laboratory studies show a normal D-dimer. The initial high sensitivity troponin is normal. TSH and free T4 are normal. EKG shows AFib with RVR, non-specific ST and T abnormalities, and incomplete right bundle branch block. Echocardiogram shows normal biventricular size and function, normal valvular structure and function, and normal atrial size. Which of the following is the most likely contributor to the patient's atrial fibrillation? A, acute myocardial infarction, B, ibrutinib, C, pulmonary thromboembolism, or D, thyrotoxicosis?
Ooh, this one might be harder.
Any takers?
Any takers? Oh, okay, right here.
I'm going to say B.
B, very good, yes. It is ibrutinib. Ibrutinib is, that is the most common cardiovascular complication from ibrutinib is AFib. Ibrutinib, as I mentioned earlier, is one of the first generation BTK inhibitors, and it, yeah, so that's basically it. So moving on, just that slide that I talked about mentioning the article. I found this a very useful and helpful article in this making this presentation. So for anyone that's interested, you can take a screenshot or a picture. But it's a very good article from the Journal of American College of Cardiology. Here are my references. And I'd like to give a thank you to the GME, to Dr. Gross as his mentor, as well as Dr. Padma Nadella. And then I'd like to thank you all for coming to the presentation today and listening so attentively. Thank you very much. And any questions?
If you're viewing online and you have a question, please enter it in the Q&A chat and we'll ask that for you. Do we have any questions or comments in the room? Oh, right down here.
This is from an experience yesterday. I was at Publix and there was a woman checking out and she was buying all these alkaline waters. And she said her husband had recently been diagnosed with cancer. And then you mentioned alkaline agents. Is that something that would be recommended in cancer treatment? I had never heard of that before. So for you to mention it even in treatment was interesting to hear that connection, if it's even something recommended.
Mm-hmm. Sure, that's a great question. As far as, those specific things, alkaline water, I have not seen any data on that. I don't know if that data exists. I would have to look it up. But in terms of the scope of this presentation, I'm not aware of any interactions with alkaline water or anything with these particular agents. So thank you for the question.
I guess I would wonder, is there enough alkaline in the water? Like, you'd probably have to drink gallons of it, right?
Yeah, I'm not sure. At baseline, alkaline water just it refers to the pH of the water as far as what they're actually putting into the water to make it more alkaline. Not sure with that. I would have to look into that more.
Interesting.
But thank you.
Any other questions or comments? Oh, down here.
Hi. Good presentation, Dr. Barker. I appreciate it, especially for us internal medicine residents here who don't have as much exposure to inpatient hematology and oncology. I was wondering, so there are a lot of recommendations about, especially for the heart failure risk of baseline echo, and then I think usually every 3 months echo for those very cardiotoxic ones. And then I saw, a little bit about EKG and troponin, and then I didn't see the details of some of those articles about risk factors. So is it standard, or is it guideline based, or is there recommendations in regards to like stress test before chemotherapy with CAD risk factors?
I did not see a standard for that. Obviously, if someone is developing chest pain, then that can be a consideration. But as far as what I saw, none of these, this was like a cardio-oncology expert panel that had helped write this article, and none of them had recommended for any of these therapies basically stress testing prior. I think it would more so be in the situation of a patient who develops some chest pain, and we're trying to treat that and stratify that.
Okay. I also saw that there were some recommendations for statin therapy. I mean, is there recommendations for more aggressive hyperlipidemia treatment or anything like that?
I think it's going to be on a chemotherapy basis. So depending on which agent you're going to be using, I know that lorlatinib, which does carry the increased risk of hypercholesterolemia as well as hypertriglyceridemia, was one that they did recommend statin use. But there are ongoing studies as to the overall benefit of starting one beforehand versus treating hyperlipidemia when it is as noted on labs. So, cardio-oncology is a very fast-growing and new field. So I suspect we will see more data on that in the future.
Excellent presentation, Dr. Barker. Thank you so much. I just had a quick question. I saw there was a mention of a cardiology referral early on. So is there any recommendations of how early cardiology should be involved in the management of a patient?
Great question. So I would say generally the first instance in which you think there could be a cardiovascular complication of a chemotherapy, it's at least warrants a phone call to a cardiologist to say, is there anything I'm not considering, or is there anything you would add? And then beyond that, just establishing them with a cardiologist for the monitoring, like echo. That's going to be important in general as well. So I think just kind of early on, specifically with more cardiotoxic medications like doxorubicin and trastuzumab and things like that, it's going to be important.
All right. Thank you, Dr. Barker.
Thank you all.